And thank you to Glaucoma New Zealand for this invitation. It's a real pleasure to be presenting you on an update to glaucoma surgery. So I just wanted to start off with some disclosures. I think it's important that you understand this presentation does not replace medical advice as treatment of glaucoma. Oh, sorry. I heard someone speaking. Sorry. As glaucoma is highly personalized. So this week is quite an important week because it is World Glaucoma Week, and green is to mark glaucoma. So I'm wearing my green scrubs here. And as for those of you who are new to the concept of glaucoma, glaucoma is a long-term, lifetime condition without a known cure. It's known as the silent thief of sight, and currently the prevalence of glaucoma in New Zealand is about 2% of the population, but it does increase with age, and it's postulated that 1 in 10 of people over the age of 70 will have glaucoma. So it's really important to go out there and spread the word about the awareness of glaucoma, and particularly with early testing for this condition. So the aim of this presentation is to give you some insight as to what is new in the surgical management of glaucoma. And to understand this concept, I really need to discuss some terminology. So I thought that this presentation will be quite useful. So within the eye, there's a structure which produces fluid, and there's a structure where fluid drains out of the eye. And the balance of this two gives rise to intraocular pressure, or IOP. And if you have too much production or not enough drainage within the eye, then the pressure gets elevated in the eye. That gives rise to damage within the nerve in your eye, and that condition is called glaucoma. Now, glaucoma can be associated with elevated pressure, but also normal tension glaucoma, you could have normal intraocular pressure. And what we know is sustained elevation of pressure, spikes in pressure, can give rise to this condition, which usually takes your peripheral vision first, and then eventually takes the central part of your vision. And it's so important to have these eye examinations because that is the only way how we can monitor and pick up this condition. So in terms of talking about glaucoma surgery, and in fact, the only way that we know to control this condition is by reducing intraocular pressure. So if you think of glaucoma as a plumbing problem, the way how we manage to control it surgically is by providing a separate pathway for fluid to drain out of the eye. So when would we consider surgery? Now, we would consider glaucoma surgery for multiple reasons. One of it is when we feel your medication is not working, i.e. if there's a failure to reach the target pressure, the pressure at which we feel will control your glaucoma. Or if you're not tolerating your medication because of allergies, for example, having really itchy, burny eye, or if you're getting systemic side effects, in other situations where we have patients who cannot put drops in their eye, for example, because of arthritis. We also know that a lot of our patients need multiple medications, and so it becomes more and more difficult for patients to remember to use the medications, or they start having added side effects associated with these medications. However, globally, especially in the last couple of years, there has been a change in how we manage glaucoma or talk about the treatment of surgery in glaucoma. And the buzzword at the moment is interventional glaucoma. Now, interventional glaucoma is an attitude in terms of changing or intervening much earlier in the treatment of glaucoma with surgery. Now, Kay, I just wonder if we could mute your microphone by any chance. So Pippa, if you could help mute all our audience microphone, if that's okay with you, because it's just coming up with random noises during the presentation. Thank you. Okay, so coming back to the concept of interventional glaucoma. So it's the attitude of intervening early in glaucoma. So the historical way of managing glaucoma is waiting for patients to progress in terms of losing more vision or showing more thinning in the nerve before we start adding more and more drops. And then we escalate towards laser. And when that fails, then we escalate to moving on to surgery. So interventional glaucoma is an attitude whereby we are a lot more proactive in managing glaucoma, and that involves early predictive ways to diagnose someone with glaucoma, more active monitoring of glaucoma, early procedural interventions, and that's what we're going to speak a lot more about today, and also addressing any adherence issues and also risks associated with using your drops. And so this is a beautiful slide and a courtesy of Dr. Ike Ahmed, who's a real big shot when it comes to talking about interventional glaucoma. But the whole concept here is that when we talk about glaucoma now, it's about putting all these factors, being much better at risk, analyzing risk factors in you developing glaucoma, much better in monitoring for progression of glaucoma, maybe using better algorithms and OCT or visual fields, genetic testing, which is now available via Australia, in calculating your genetic risk factors, using AI to predict or pick up glaucoma. So there's a lot more about what's happening in glaucoma, not just about surgery. And today I'll mainly be talking about laser, mixed procedures, and a little bit about drug delivery, because that's a new exciting area in glaucoma. So I'm going to start off with selective laser trabeculoplasty. So within the eye, there's a structure here which is called the trabecular meshwork, and that is the critical area which produces, which allows us to drain fluid out of the eye. And so what happens is we're using SLT, which is a non-invasive laser technique. We target that drainage of your eye and you allow more fluid to drain out of the eye. It's a very safe way of lowering the pressure within the eye. It's typically painless and it works in approximately 70% of patients. It's done as a day procedure, and most patients can just carry on with your normal activities of daily living following the procedure, and most people can actually even drive following the procedure. So what's changed is that there's been this major trial coming out from the UK, which is called the LIGHT trial. And now we have the 6-year data from the LIGHT trial, which has shown that it's a very safe and effective way of lowering the intraocular pressure. And also these patients, when they had SLT as the first line of treatment, not as opposed to eye drops, they actually had less chances of requiring more invasive glaucoma surgery or interventional glaucoma, and also cataracts at the 6-year mark. So much so that now SLT is being coined as one of the first line treatment for open angle glaucoma in America and in the UK, and also based on the European guidelines. So what's interesting is that now there are companies which are coming up with this concept of what's called direct SLT. So if any of you have had SLT, normally it involves putting a lens on the surface of your eye coupled with some gel. The procedure normally takes a couple of minutes anyway, but in this procedure, or using direct SLT, you're not using a coupling gel. Essentially what happens is the patients have local anesthetic. The operator decides how much they want to treat the eye by. You have the special relaxing clip on placed on the eye, and they basically press the little trigger there. A couple of seconds later, just like that, it's targeting that drainage of your eye, and that's it. So it's exciting. It's got FDA approval. It has now been used in Germany and the UK. Still hasn't really had much uptake in America, but who knows what might happen when, if and when it comes to New Zealand. But an exciting area, particularly when we're dealing with increasing demands from the public health sector, particularly to have these interventions. So I'm going to move on and talk about minimally invasive glaucoma surgery. So big news this year is that Southern Cross, which is the biggest private insurance provider in New Zealand, now covers the course of mixed procedures. So if you have glaucoma and it's not under control, and particularly if you have glaucoma and you're undergoing cataract surgery, it's really important that you speak to your healthcare provider, your ophthalmologist, if you are suitable for any of these procedures. And in Auckland, all these procedures are available through the public hospital. So you should have that conversation with your ophthalmologist regardless. So the iStent is the smallest medical device approved for use in the human body, and it's less than 1/3 of a millimeter. And it's made from titanium. And the way how it works is that it allows more fluid to drain out of the eye. It's very much like a cardiac stent. It's done at the time of cataract surgery, and it's used in the treatment of mild to moderate glaucoma. And studies have shown that it lowers the pressure by 30%, and that is the equivalent of lowering one glaucoma medication in patients. So what's new and exciting is that now the company has produced the iStent Infinite, which now has 3 stents inserted at the same time, as opposed to the current model, which puts 2 stents, and 3 stents works better than 2 stents. And we should have that at the later part of this year. So I'll keep you posted on the results of that. But essentially, that's the little small stent, which is placed in an injector. And we basically use the same incisions that we've already done at the time of cataract surgery. So you're not actually adding more cuts from the time at the same time when you have the surgery. You can see that essentially very similar to a cardiac stent in coronary stenting procedure. You're stenting that trabecular meshwork with that drainage mechanism to allow more fluid to drain out of the eye. So the other exciting product here is the iDose, also produced by the same company. So what this does is that it has a certain drug in it, which is travoprost, which is very similar to bimatoprost and latanoprost, which most of you are on. And what this device is, a drug-eluting device. So very similar to coronary stenting, where you have drugs embedded in the stent to stop the coronary arteries from closing over. Here, in a similar procedure to the iStent, you have travoprost within that device, and it just slowly starts to release that drug over the course of the day. And what I love about this is that you are targeting drug delivery to that tissue which you actually need to focus on. And that means that our body normally stops drugs penetrating the eye through the cornea. And so now you're bypassing that mechanism. So you're going to have more drugs targeting that tissue. And particularly, there's less side effects, systemic side effects associated with these medications. And most of you are aware that most of our medications has potential side effects on the body. Oops. Somehow we went all the way to the end of our slide. Sorry about that. So just moving forwards. So the next procedure I wanted to speak to you is called a goniotomy. So goniotomy is a procedure where the trabecular meshwork is very gently excised during surgery. So we use this knife, which is called a KDB goniotomy knife, and it's basically specially designed to create a precise incision over the trabecular meshwork. And this blade has 2 parallel sides to it. And so what that does, it basically allows stripping that tissue in a nice regular manner, and then we can just gently peel it off. And similar to the iStent, it's minimally invasive. It spares the conjunctiva, which is that nice, thin covering, transparent tissue covering the eye. And that means that further down the road, if we ever have to do a trabeculectomy, we are not at risk of causing the trabeculectomy to fail. And finally, it can also be used in patients who have narrow drainage angle glaucoma to be treated. So this is a surgical video of what the KDB effect is, and basically that white tissue that you can see there is when I've actually gently stripped off that membrane, and you've got direct access into that drain for fluid to drain out of the eye. The next device here is called a PreserFlow implant, and this is a micro-shunt. And what this device is here, and you can see it's really small and tiny, it's a small flexible tube which is made from a biocompatible material which is called SIBS material, and that's implanted into the eye to create a special pathway for fluid to drain out of the eye. So this basically diverts the flow of the aqueous humor from inside the eye, the anterior chamber, onto the surface of the eye. and that forms a little blister, also known as a bleb. And that bleb acts as a reservoir underneath the conjunctiva, and that slowly then seeps off onto the surrounding tissue around the eye and essentially lowers intraocular pressure. So the benefits of this procedure is because it's minimally invasive and you have very little incisions made, it means that the patients have a much faster recovery process compared to a procedure like a trabeculectomy. It's also associated with a lower risk of complications when we compare it to trabeculectomies, which is that classical procedure which we've done to control and treat glaucoma. And there's also a potential for reduced dependence on medications. So you can see in this picture here where you've got this beautiful stent being inserted into the eye and basically fluid draining out of the eye through that little device, which acts like a straw, and it drains onto the surface of the eye. The next procedure to discuss is the Micropulse laser. So this is a type of laser which is applied on the surface of the eye, and you can see it's basically holding a little pen essentially on the surface of the eye. And what that does, it delivers energy straight onto the ciliary body, which is that structure which produces fluid. So it's one of the only techniques to not only switch off the tap, which produces fluid, but it also causes contraction of the muscles, which allow fluid to drain out of the eye. And so you also have an added effect of lowering the pressure by allowing more fluid to drain out of the eye. And this doesn't require any cuts and can be done at any stage of your glaucoma treatment. Now, one of the more recent devices which has been discussed, particularly with some of our experience from Australian counterparts, is this device here, which is called the mini jet. So the mini jet is the only device which currently targets an area in the eye, which is called the supraciliary space. So this is a space just under the wall of the eye, and it's normally closed. So it's the space here. So it's normally closed off unless if you have what's called a cleft created. And we sometimes can see clefts in patients who've had trauma. And what we found as glaucoma surgeons is that when you have a cleft, that's a very powerful way to reduce the pressure within the eye. So what these companies have done is they've used this little device, which is made from a very flexible silicone, and it basically is inserted into the supraciliary space. So it's forming a very controlled cleft, and it is made from a very porous material, which is also biologically inert. So you don't have as much inflammation and scar tissue associated with this device. And the benefits of it, apart from being a minimally invasive glaucoma surgery, is that it also spares the conjunctiva, and the reduction in pressure is between 30 to 40%. There isn't too much too much exposure in New Zealand anyway, but what I find is that most devices which are available in Australia eventually kind of make their way to New Zealand. So let's watch and see what happens in this area. So when it comes to these devices, I'm always at these different conferences and people are asking about the evidence for the use of these devices. What I can tell you is that if you do a PubMed research, which is essentially this large database available to everyone, and you look up just minimally invasive glaucoma surgery, there are hundreds of papers on this area. And you can actually look up individual devices. But one of the most convincing slides I've seen recently from local evidence. So this is a slide from a poster presentation at the Royal Australian New Zealand College of Ophthalmology conference that we just recently had. And when they looked at the side effects of the safety profile of all these different individual devices, they have found them to be very safe for the use in the eye. So the future of glaucoma is very exciting. We've got all these different devices which are already available for use in New Zealand, but more and more information is coming in. And I think the whole idea of this conversation really is for you to be aware that they're available. And it's up to you to actually have that discussion with your ophthalmologist too, to ask them if you may be suitable for these different devices. And watch the space, because what is current today is such a fast evolving area, may be quite different from what the advice may be in 6 months' time, but definitely watch the space. So thank you very much for your attention.
Is iridotomy fairly common in New Zealand?
Hi, Judith. Thank you for that question. So when you ask about iridotomy, so it's a laser procedure that we usually do, which is peripheral iridotomy, and it's usually given or offered in the treatment of patients with angle closure or what's called narrow drainage angles. So there's a continuum, so that's within this area of narrow drainage angles, patients who are called primary angle closure suspect, primary angle closure, and patients with primary angle closure glaucoma. And to answer your question, so is iridotomy quite commonly offered in patients with narrow drainage angles? Yes, it is. And certainly there are specific indications for it. We would certainly discuss it with every patient, but clinically we usually offer it to patients who are high risk of developing angle closure, or in situations where it's their only eye, or a strong family history of glaucoma, or if the patients are going to have routine dilated fundus examinations, for example, if they are diabetics and we have to keep a close eye on the back of the eye. Hope that helps.
Okay, thank you very much. Yes, I had one in Australia, and it's been very, very successful. I'm just very grateful to have had that. I was just hoping that it was available to other people in New Zealand as well.
Yeah, it certainly is. It certainly is. Thank you, Judith.
Okay, thank you.
Could you just talk a little bit about, as you get older, you get multiple medications, and then you look on the health warnings and they say, don't take this medication if you have glaucoma. But the medication is for a, reasonably serious condition. What's the situation with these drug interactions with glaucoma?
So Brendan's kind of alluded to a couple of interesting or important points in terms of your glaucoma management. So the first question was the first couple of points. So firstly, polypharmacy, where you actually have multiple glaucoma medications being prescribed to a patient. And two, the importance of drug interactions, either between those glaucoma medications or with your own other medications that you use for other conditions, other systemic conditions. So what I would suggest is, Brendan, is that it very much is personalized. It depends on the type of glaucoma you have and how severe the glaucoma is. So you have a lot of health warnings because you need to be aware of it. And I think the most common association would be amitriptyline in patients with narrow drainage angles. So amitriptyline is prescribed for a whole lot of patients because they have neuropathic pain, or also for depression and a few other indications. But if you have narrow drainage angles, it can increase your risk of developing angle closure glaucoma. However, if you discuss this and you bring your list of your medications at every consultation you have with your glaucoma specialist, the glaucoma specialist needs to be aware that you may be started on these medications. They'll advise you based on how bad your glaucoma is and your risk factors of how important it is for you to be, what are the risk profiles associated with your underlying condition, and provide you with alternatives. The alternatives may be, in this particular example, doing laser peripheral iridotomy, like what Judith had mentioned earlier, whereby once you have the laser peripheral iridotomy, you can certainly use that medication such as amitriptyline, because you're no longer at risk of developing acute angle closure glaucoma, where your pressure suddenly shoots up and you could potentially lose vision within hours. So in that situation, you are reducing your risk by doing an intervention, which will allow you to continue using your amitriptyline, for example. But in other situations, so for example, if you have certain very severe forms of glaucoma, or quite advanced form of glaucoma, we may suggest that you may not be suitable to use that particular medication. So just thinking at the top of my head, for example, or we may also suggest modifying when and if you take the medication. So thinking of an example at the top of my head would be blood pressure medications and normal temperature glaucoma. So normal temperature glaucoma, there has been theories that lack of blood perfusion to the nerve may be giving rise to progression of glaucoma. So if you are taking blood pressure medications, particularly at night when your systemic blood pressure is already going to be much lower, taking those medications at night may further reduce the perfusion of blood to an already diseased nerve. So what we would suggest is take the blood pressure medications in the morning as opposed to night. So to summarize that, Brendan, is that what's important is trusting and your glaucoma physician, and also having a little chat with them every time you go to that consult about what are the new list of medications you're taking and whether that could have any interactions. And vice versa, when you speak to your GP about being started any new medications, if there is any doubt, ask them to drop an email or a message to your glaucoma surgeon before you're started the medications. And it's not uncommon for me to get, to get emails about this and offer advice on it. So there you go. I hope that helps.
Thank you. Yeah, that's very clear.
Thank you. Thanks, Brendan.
Lucy asked, thanks for the presentation. You stated that one treatment was available in Auckland with the single health agency. Will treatments be more widely available nationally?
Well, that's a hard one to answer, Lucy. And I think that really depends. I think it's a question for Ministry of Health and probably Te Whatu Ora. So all of these devices are available in New Zealand, in Auckland, I should say, partly because all of us working in Auckland at the moment are quite comfortable with these devices, and we've gone for all these different conferences and we've sat down with our clinical team to actually look at the cost-effective ratios and provided them with enough evidence. And it goes through a whole bunch of discussions, roundtable discussions, paperwork before a particular device is actually introduced into the hospital system. I think from your perspective, Lucy, is that what you can do is certainly the patients actually have a lot more say in advocacy. So what you would say is that if such a device, so firstly, you should ask your glaucoma surgeon, is that device available? If it's not, why not? And then therefore asking the right questions, writing to your health board and asking them, why isn't this particular device available in my district health board if it isn't? And if it is a matter of funding, to actually ask them to, getting all the different research papers to advocate for that, probably getting in touch with Glaucoma New Zealand to see how much of a push you can have from that factor. If it comes down to the ability of the surgeons, because not every surgeon will be comfortable with using all these different devices. And if it's a surgeon-based, lack of access, then it's a question of whether you could be referred to a different center to have access to it. So I suppose I can't quite answer that question in terms of funding and what's available in different health boards, but I think the idea in New Zealand is that we're trying to move towards a vision whereby Te Whatu Ora, regardless of which DHBs you belong to, that everyone has the equal access to care, but certainly something which is beyond my abilities to answer in terms of what the different district health boards will offer. So I hope that helps, Lucy.
Diva, I had trabeculectomy on both my eyes about 5 years ago. If some of these procedures that you've talked about now, were they not available at that time, or is it I would have to have had trabeculectomy anyway? Could it mean that
Yeah, it's a very good question, Catherine. So Catherine, 4 to 5 years ago was when we were first starting to introduce these minimally invasive glaucoma surgery in New Zealand. And so, but so there's multiple factors. Firstly, it was being introduced then, but the second point is that trabeculectomies, so depending on how severe your glaucoma is, so if you had really advanced glaucoma and if we had to get your target pressures down to below 10 or the very low teens, the most powerful operation would be a trabeculectomy. So I do feel that based on your very positive experience that you had mentioned earlier, Catherine, then and how close your relationship is with your eye surgeon, it certainly was the right advice for you. So I would say definitely trust your surgeon in making that right decision for you. But certainly these technologies are evolving, and our current experience, especially with the eye stents in New Zealand, has been for the last 5 years.
Well, thank you. Thank you.
Yeah. And I think where they can put the medication into the eye, is that only for those, though you mentioned there were 3 medications that are within those stents. Will they expand that? Will there be more medications that they can put in? Why is it only those 3?
Well, currently there's other devices which are also going to be producing or releasing different, so there are different types of drug-eluting stents.
Yep.
So with the iDose, from my understanding, it's currently travoprost. I don't know why travoprost was picked. Certainly, travoprost does actually have quite a good side effect profile compared to the other prostaglandin analogs. But I think there are different drug-eluting devices which will be coming into the market with different choices of agents. But it makes sense to me to pick a prostaglandin analog because it's the first-line treatment.
Thank you very much, Divya. We
My pleasure.
really appreciate your time. That was very interesting, exciting to see where we're going, and sounds like the next 4 to 5 years are going to be just as exciting as the last.
Yeah, I think that's the best thing about glaucoma. I came back from my fellowship 5 years ago, and I think when I came back 5 years ago, what I could offer to New Zealand was that I had a fellowship which was rich in minimally invasive glaucoma surgery experience. And every couple of months, there's something new happening overseas. And it's just nice to be able to offer something else for our glaucoma patients.
Yeah.